Okay, so today we're going to talk about anterior mediastinal masses. We'll talk about a radiological scheme for the boundaries of the mediastinal compartments based on the lateral chest radiograph. We will discuss the differential diagnosis of anterior mediastinal masses, and we will review some clinical imaging features of various anterior mediastinal lesions. So the first question is, how do we divide the mediastinum? Is a nice example of somebody with an anterior mediastinal mass. So I find that the best classification scheme is the Felsen division of the mediastinum based on the lateral chest radiograph. We draw a vertical line along the anterior border of the trachea. It comes down posterior to the heart and down to the diaphragm. We draw a second line 1 centimeter posterior to the anterior border of the vertebral bodies. Everything anterior to this line is anterior mediastinum. Between the two lines is middle mediastinum, and behind that line is posterior mediastinum. So it's important to note that this is different than the anatomic classification of the mediastinum. In the anatomic classification of the mediastinum, the trachea and the heart are placed in the middle mediastinum, and the esophagus is placed in the posterior mediastinum. Now, any type of division of the mediastinum is arbitrary. There are no fascial planes that clearly delineate one compartment from another. But it is important to realize that there is now an accepted definition for radiologists put out by the International Thymic Malignancy Interest Group for classification of the mediastinal compartments. So this is division of the mediastinum based on cross-sectional imaging. So instead of anterior, middle, and posterior, these compartments are called prevascular, visceral, and vertebral. In this classification scheme, the prevascular compartment is this area here, anterior to the great vessels and the heart. The visceral compartment, or what we would call the middle mediastinum, this includes the blood vessels and the heart. And the vertebral compartment is posterior to that, or what we would call the posterior mediastinum. So if you're asked on an exam, this is the accepted definition as far as radiology goes for the mediastinal compartments: prevascular, visceral, vertebral, and we have discussed the divisions. So let us start with this case here. So we have a mass here that causes deviation of the trachea. It seems to extend up into the neck. We can see the extends to the anterior mediastinum. The bulk of the lesion appears to be above the aortic arch. So what could this be? Well, whenever we have a mass that is causing deviation of the trachea and seems to be extending down from the neck, we have to think of masses of thyroid origin, and that indeed is the case. When we look on the CT scan, we can see that this mass does connect to the thyroid gland and is pushing vessels aside. So this happens to be an example of a benign thyroid goiter. So here we have another case where we have a mass that is extending down appears to be from the neck. Notice we don't see the lateral border of the lesion above the clavicle. That is the cervicothoracic sign. That's also an indication that the lesion is blending in with the soft tissues of the neck. Again, there's deviation of the trachea, but this time the mass extends down behind the trachea into the middle mediastinum. So what could this be? Well, again, this turns out to be a thyroid mass. This connects to the thyroid. Most masses of thyroid origin will extend to the anterior mediastinum, but occasionally they can extend down posterior to the trachea to the middle mediastinum. Here in this example, again, we have a mass that seems to be extending down from the neck, causing deviation of the trachea. The bulk of the mass here extends to the anterior mediastinum above the level of the aortic arch. So again, we're thinking of masses of thyroid origin. Again, this connects to the thyroid gland. But what is different about this lesion is that instead of pushing vessels aside, this is encasing the blood vessels. Here also there is a left pleural effusion. So this is an example of a malignancy. This is thyroid cancer. So thyroid goiter, we want to think of masses of thyroid origin whenever we have a mass that deviates the trachea and extends into the anterior mediastinum. Occasionally they can also extend to the middle mediastinum. That path of extension is important because if it extends to the anterior mediastinum, a cervical incision can remove the mass. However, if it extends into the middle mediastinum, that would require sternotomy for operative removal of the mass. So on a chest radiograph, whenever we have an inlet lesion that deviates the trachea, especially if it extends to the anterior mediastinum with the bulk of the lesion being above the aortic arch, we want to think of masses of thyroid origin. So on imaging, to say that the mass is of thyroid origin is to be able to connect the mass to the thyroid. Portions of it will be high in attenuation, even on non-contrast CT. Remember that the thyroid concentrates iodine. Also, the thyroid is a vascular organ, so if we give contrast, there will be marked enhancement. Thyroid goiters can be inhomogeneous with cystic components. They might contain calcifications, as in this example that we have seen, but benign goiters usually push vessels aside without infiltration of the fascial planes between the mass and the blood vessels. So as we've said, these thyroid goiters can extend to the middle mediastinum behind the trachea, as in this example that we have already seen. This example of a thyroid mass here connects to the thyroid, extends down posterior to the trachea. Thyroid cancer can be indistinguishable from thyroid goiter. Some clues to consider if we're thinking about malignancy: encasement of blood vessels, lymphadenopathy, marked irregularity of the gland contour, loss of mediastinal fascial planes, cervical or mediastinal lymphadenopathy. In this case, there's also a left pleural effusion. So these are signs that would suggest malignancy. Now, what about this next case? Here we have a mass. So what clues can help us to localize the mass? Well, one thing we notice is that we can see the left pulmonary artery through the mass. That's an example of the hilum overlay sign. So that's telling us that the mass is not in contact with the hilum. Is it anterior or posterior to the hilum? Well, let's examine further. We can see the aortic knob and the descending thoracic aorta clearly, so it is not in contact with the aorta. The aorta is a posterior structure, so that directs us to the anterior mediastinum. In addition, the left heart border here is obscured, which confirms that this must be an anteriorly located lesion. And on the lateral view, that confirms our suspicion. Here we have an anterior mediastinal mass. And on the CT, we have a focal, large anterior mediastinal mass. There's no lymphadenopathy, no masses elsewhere. So this is a very nice appearance for a thymoma in this particular case. Now, what about this case? Again, we have an anterior mediastinal mass, but this time on the second image, we have these pleural lesions. So these are drop pleural metastases. So if we have an anterior mediastinal mass with drop pleural metastases, we need to consider invasive thymoma. So thymoma usually arises in patients greater than age 40. 50% will have a paraneoplastic syndrome, especially myasthenia gravis. 30 to 50% of patients with thymoma have myasthenia gravis. 10 to 23% of patients with myasthenia gravis will have thymoma. These are some other paraneoplastic syndromes that can also be associated with thymoma. So on CT, a thymoma can give us a focal mass or swelling in the region of the thymus. You might have calcification, as in this example. They can be invasive or non-invasive, and it's spread beyond the capsule that determines that. So often the pathologist will need to make that determination. 30% are invasive. So here's an example of an anterior mediastinal mass here. You can see it here on the frontal, but the lateral view confirms it's in the anterior mediastinum. Again, another example of a thymoma. This was a patient with myasthenia gravis. So some clues on imaging that we're dealing with an invasive thymoma: if we have irregular tumor margins or invasion of mediastinal fat, invasion or encasement of vessels, irregular interface with lung, extension across the midline. Most importantly, drop metastases to the pleura, pleural nodules, or metastases to the pericardium. So invasive thymoma rarely metastasizes outside of the thorax, so the mode of spread is usually to the pleural surfaces. So if we have an anterior mediastinal mass with drop pleural metastases, we want to think of invasive thymoma. Thymic carcinoma is also a malignancy of the thymus. This is histologically distinct from invasive thymoma. This is a very aggressive tumor. This can also give you a large anterior mediastinal mass. This tends to be more invasive than invasive thymoma, so it can cause obstruction of the superior vena cava, and also it's more likely to give you hematogenous metastases, so you may have lung nodules or mediastinal lymphadenopathy. So thymic carcinoma is more likely than invasive thymoma to result in invasion of great vessels. Here we have a thymic carcinoma. Here there's some extension to the with impressive narrowing here of the superior media more likely to give you mediastinal or hyolymphadenopathy, can give you phrenic nerve palsy, and also hematogenous metastases to the lung or the liver. Okay, so here's our next case. We have a 37-year-old man with myasthenia gravis. What do we think? Well, there's this focal nodule here within the anterior mediastinum. Of course, your first thought is going to be thymoma, but let's investigate further here. So here it is on CT. So here we have MR at 1.5 Tesla, TE of 2.2, TE of 4.4. So this is an out-of-phase image. This is an in-phase image. We notice that there's signal dropout here on the out-of-phase image. So does that help us? And of course the answer is yes. So with signal dropout, then we don't think that this is neoplasm. We don't think this is thymoma. So this is more consistent with, or this is consistent with focal thymic hyperplasia. This is a 12-year-old with myasthenia gravis who has this anterior mediastinal mass. Now, 12 years old is too young, even with myasthenia gravis, to get thymoma. Notice the shape of the lesion. It's in the shape of an enlarged thymus. It's kind of boomerang in shape. So this is the picture of diffuse thymic hyperplasia in this 12-year-old. Now, MR with in-phase and opposed phase imaging can help us differentiate thymic hyperplasia from neoplasm. If there's dropout in signal on the out-of-phase images, and at 1.5 Tesla at every 2.2 milliseconds, you will be in phase and out of phase. So at 2.2 milliseconds, you will be out of phase. At 4.4, you will be in phase. And so if there's dropout in signal on the opposed phase images, then that supports a diagnosis of thymic hyperplasia. So here's another example, patient with this kind of focal nodule here in the anterior mediastinum. Here's our in phase, out of phase sagittal image. Notice there is signal dropout there. Also on the axial images, in phase, out of phase, again we have signal dropout. So that confirms that this is thymic tissue, so that is not a thymic neoplasm. So our next case here, this is a patient who presented to the emergency room, a 46-year-old woman with chest pain, tachycardia, and shortness of breath. She had a CT scan for pulmonary embolism. There was no pulmonary embolism, but there was this anterior mediastinal mass that drapes over the heart. An additional finding is this thyroid enlargement. So how do we put all of this together? Well, this was a patient with Graves' disease and hyperthyroidism, and it turns out that that also can be associated with thymic hyperplasia. So that was a way to put the findings in this case together. So with thymic hyperplasia, you can have true thymic hyperplasia, which is hyperplasia of the cortex and medulla. That can be associated with Graves' disease, thyrotoxicosis, also with thymic rebound and acromegaly. Remember, rebound hyperplasia occurs after treatment for an acute illness with steroid, or especially for malignancy with steroids, radiation therapy, or chemotherapy. And usually in young patients, the thymus may atrophy, but when it grows back bigger, and we get thymic rebound hyperplasia. So with true thymic hyperplasia, we get a diffusely enlarged thymus that preserves its normal shape. There's another form of thymic hyperplasia called thymic lymphoid hyperplasia. Here we get proliferation of medullary B cell lymphoid follicles. This can also be associated with myasthenia gravis and these other disorders. Here the thymus may be normal, can be diffusely enlarged, or it may contain a focal mass, and this can be very confusing. This can be confused, or this can be mistaken for thymoma in a patient with myasthenia gravis. So here is diffuse thymic hyperplasia here, in this case of the 12-year-old with myasthenia gravis. Now, thymic hyperplasia turns out to be the most common abnormality of the thymus associated with myasthenia gravis. In-phase and out-of-phase imaging can help to differentiate thymic tissue from malignancy. So dropout of signal on the out-of-phase images supports thymic tissue as opposed to malignancy. Here's a case of some thymic hyperplasia here, in phase, out of phase, dropout in signal. We can call this thymic hyperplasia. We do not think that that is malignancy. On the other hand, there's a case of non-Hodgkin's lymphoma of the thymus. Anterior mediastinal mass does not drop out in signal, so here we will be more concerned with malignancy. Now, in terms of quantitative measurements to determine if there is sufficient dropout in signal, usually you can eyeball it, but these are some quantitative measurements that are present in the literature. So there is the the chemical shift ratio here, where we take the thymus opposed phase divided by muscle opposed phase, and we take that quantity and divide it by thymus in phase and muscle in phase using this equation here. And if this ratio is less than 0.7, it's considered benign. Between 0.8 and 0.9, it's indeterminate. Greater than 1, then you would be concerned about neoplasm. What is probably easier to use, though, is the signal intensity index. Here you don't have to measure signal intensity from muscle. You just take the in-phase signal intensity of the thymus and the out-of-phase signal intensity of the thymus, do that subtraction, divide by the in-phase signal intensity of the thymus. It is important that your in-phase and out-of-phase images here are acquired on the same pulse sequence. So here, with the signal intensity index, if you get a number greater than 8.9%, then we can consider the lesion benign. So if it's not obvious if it's dropping out in signal when you're eyeballing it, you can apply this equation to help you decide between benign and indeterminate lesions involving the thymus. So here's our next case. We have an anterior mediastinal mass here. T1 weighted image. It looks like this, somewhat higher than fluid signal intensity, very bright on T2 weighted imaging. Pre-GAD, post-GAD, subtraction. Sometimes it's hard after you've given contrast to see if there is enhancement in the lesion. This is where subtraction imaging can be very helpful, and we see that on the subtraction images there is no enhancement of this lesion. So we can call this a thymic cyst. Thymic cyst can be higher than fluid signal on T1 weighted images and also higher than fluid attenuation on CT. So this is where MR with contrast, looking for contrast enhancement or lack of contrast enhancement, can be very helpful for diagnosing a thymic cyst. Here we have another cystic lesion here in the anterior mediastinum. There's bright signal on the T2 weighted images. Notice after contrast, though, it is multiloculated. There is thickened enhancement of the walls. So here we cannot assume that this is a benign lesion. Here we do have to be concerned about malignancy, and this was cystic change within a thymoma. So this was a cystic thymoma. Here's our next case. We have a mass here that obscures the right heart border. It's in the right cardiophrenic angle. So it's overlying the heart here on the lateral view. But on the CT, we see that it is mostly fatty in attenuation. It does contain some strands of soft tissue attenuation. Well, what could this be? Well, after we look carefully at the diaphragm and exclude the possibility of a diaphragmatic hernia, what else can we consider? Well, it could be a mass of fatty origin, like a low-grade liposarcoma with these soft tissue elements in there. But another lesion to consider is a fatty mass of thymic origin. This is a thymolipoma. So thymic cysts can be congenital or acquired. Acquired thymic cysts can be secondary to inflammation, cystic degeneration of the thymus, or you can have cystic changes within neoplastic lesions, as we have seen. So for a benign thymic cyst, there should be no enhancement. It should have a very thin wall. It should not be multiloculated. You should not have significant enhancement of the wall. And usually these are fluid in attenuation, although some articles will recommend surgery, even still, to make sure that it is a benign lesion. So usually benign thymic cysts, fluid attenuation, no enhancement, no thickening of the wall, usually unilocular. Thymolipoma, this is a very slow-growing neoplasm. It's a fatty lesion. These are usually large at the time they're diagnosed. They can be pedunculated, and they may actually move on decubitus views. Usually they do not cause much in the way of symptoms. So here you will have a large anterior mediastinal mass, but on imaging it is mostly fatty in attenuation. So it's a large fatty mass arising from the thymus gland. That's a thymolipoma. All right, so here's our next case. We have an anterior mediastinal mass, and the finding on the second image, look at the adrenal glands. We have bilateral thickening of the adrenal glands. This patient has adrenal hyperplasia. How can we put that together with this anterior mediastinal mass? Well, if I tell you this patient also has Cushing's, then you should be able to put it together. This is an example of a Thymic Carcinoid tumor. So these tumors, 50% are functionally active. They produce ACTH, which can result in Cushing's syndrome. Interestingly, carcinoid syndrome does not occur with thymic carcinoids. 20% are associated with MEN syndromes. These can be aggressive with Mets at presentation. So we have a large anterior mediastinal mass here with bilateral adrenal hyperplasia. Patient may have Cushing's here, so we think of thymic carcinoid. So these can be aggressive. They can cause obstruction of the superior vena cava and can have metastatic hematogenous metastases. So here's our next case. We have this bulky anterior mediastinal mass. And on CT, in addition to the bulky anterior mediastinal mass, another important finding is this lymphadenopathy here in the axilla. So we have an anterior mediastinal mass that is quite bulky with axillary lymphadenopathy. Here we need to consider lymphoma. This was Hodgkin's lymphoma. So Hodgkin's lymphoma, 2 age peaks, young and older. And most of these patients with Hodgkin's lymphoma who have mediastinal involvement will have involvement of the prevascular nodes, will have involvement of the anterior mediastinal nodes. So Hodgkin's appears to be unifocal in origin and spreads by contiguity to adjacent node groups. It's unusual for Hodgkin's to skip lymph node groups when it spreads. Nodular sclerosing, this is the most common type to involve the anterior mediastinum and the thymus. So here is the staging system for Hodgkin's lymphoma. The prognosis depends on the extent of disease and the cell type of the tumor. So bulky anterior mediastinal mass, especially in a young person who has lymphadenopathy elsewhere. In this example that we've seen, there's axillary lymphadenopathy. We need to think of Hodgkin's lymphoma. So the nodes are usually homogeneous, but they can be cystic and necrotic. Nodes can calcify or become necrotic after treatment. Involvement of the lung parenchyma can occur, but it's usually spread from the lymph node into the adjacent lung parenchyma. Non-Hodgkin's lymphoma, this can also involve the mediastinum. The disease here is probably systemic at presentation. It can skip lymph node groups when it spreads. The staging system is the same. Imaging features the same as Hodgkin's disease. There is a form of non-Hodgkin's lymphoma called primary mediastinal large B-cell lymphoma. So this arises from thymic medullary B cells. Primarily involves the mediastinum and presents as an anterior mediastinal mass. So this can occur especially in HIV positive patients. Gives you a bulky large anterior mediastinal mass, as in this example here. And here it is on CT, this large bulky anterior mediastinal mass here. Looks just like Hodgkin's disease. So this is large B-cell non-Hodgkin's lymphoma. So for follow-up findings in patients with lymphoma, after treatment, they can still have residual mediastinal masses that may represent residual fibrous tissue, so-called sterilized lymphoma, especially common with nodular sclerosing Hodgkin's disease. This is where follow-up PET-CT can be helpful to differentiate this from active tumor. So before therapy, we have all of this lymphadenopathy. After therapy, we still have this residual mass in the anterior mediastinum. So do we have active disease or not? This is where PET can be very helpful. Before therapy, we see all of this activity within the lymph nodes. After therapy, no more activity in the nodes. So there is no active disease here as demonstrated by the PET scan. So for follow-up of these patients, we usually use PET-CT. Now, other things that can happen here is recurrent Hodgkin's can occur within the cardiophrenic angle lymph nodes. So that can give you cardiophrenic angle masses from enlargement of the cardiophrenic angle nodes, as in this example here. So the recurrent Hodgkin's can occur within this lymph node group. It's an unusual lymph node group to give you lymphadenopathy. So here's our next case. We have a patient with this large anterior mediastinal mass, multiple nodules within the lungs bilaterally, so we're thinking about malignancy on CT. We have this large anterior mediastinal mass. We see the left pleural effusion. We see these bilateral lung nodules. This, it turns out, is a young man. So what can this be? Well, certainly could be lymphoma. That's a consideration. We've discussed Thymic Carcinoma. That can give you hematogenous metastases. But in a young man, another consideration is a malignant germ cell tumor arising primarily in the mediastinum. And the most common of those is seminoma. This was a seminoma. So in this example, here also we have an anterior mediastinal mass. A clue on the lateral view is we have some calcification here within the lesion on the lateral view. And on the CT, we notice calcification. We also notice fat and fluid. So what does this turn out to be? This is a teratoma, also a germ cell tumor arising primarily within the mediastinum. So these mediastinal germ cell tumors arise from germ cell rests in the mediastinum. Remember that the germ cells in embryology start out in the midline and then they migrate to where the gonads are to form the gonads. But you can have germ cell rests that are left behind anywhere in the midline, and this is why you can get germ cell tumors anywhere along the midline, such as the corpus callosum or the anterior mediastinum. So the benign germ cell tumors, the teratomas, these can occur in males or females, but the malignant primary mediastinal germ cell tumors, the most common of which is seminoma, those are almost always male patients. So these mediastinal teratomas, these are the most common of all mediastinal germ cell tumors. So they can be benign, most cases are, although you can have immature forms and you can have forms with malignancy. Again, males more common than females for malignant teratomas. Most patients are young. Pancreatic tissue or intestinal mucosa within the tumor can secrete digestive enzymes, and that can cause rupture into the lung, airway, pericardium, or pleura. So large tumors can cause compressive symptoms, trichoptisis, coughing up here. Remember, these teratomas might contain hair, is a rare but characteristic symptom of a ruptured mediastinal teratoma. On CT, we can see multilocular cystic mass that might contain fluid, soft tissue, calcium, and fat, but the most specific feature is fat to make the diagnosis of a teratoma. So a fat fluid level is a specific finding, but only seen in about 11%. Malignant teratoma is more likely to be solid and less likely to contain fat. So here's a lesion in the anterior mediastinum, has calcification, but also has this fat within it, more fat here, so that is a teratoma. Another example, some calcification, fluid, and also a fatty component, another example of a primary mediastinal teratoma. The fat fluid level here is a very specific feature for a mediastinal teratoma. Here's a plug of fat here within the fluid, but that is only seen in about 11% of cases. Now, mediastinal seminomas, so these malignant primary mediastinal germ cell tumors, again, almost always male patients, 10% will have increased HCG, and they tend to occur in young males. So these are usually homogeneous solid masses. They can have well-defined margins that can invade adjacent structures. They can be very aggressive. Here you can see this narrowing of the brachiocephalic vein and superior vena cava, very aggressive anterior mediastinal tumor. So if we see something like this in a young man, your first thought might be lymphoma, but you also need to consider a malignant germ cell tumor like seminoma in these cases. Sometimes we can have cystic degeneration. So here there is cystic degeneration within this seminoma. Notice it is multiloculated and there is thickening of the walls. So we don't want to assume that this is a benign thymic cyst. Here we do need to consider thymic neoplasms. If we have an appearance like this, we need to consider neoplasms of the mediastinum. In this case, it was a cystic seminoma. Non-Seminomatous malignant germ cell tumors, again, almost always males. These are the cell types. 20% can have Klinefelters, and these tumors can produce HCG and AFP. These also can be very aggressive anterior mediastinal masses, as we see here. So large heterogeneous mass, you might have necrosis and hemorrhage, often infiltrative, and these may invade surrounding structures. Okay, so here we have a patient with a right cardiophrenic mass, mass in the right cardiophrenic angle. There is a differential for this. On the CT, we see that it is fluid and attenuation in contact with the pericardium. In this case, this is a pericardial cyst. So pericardial cyst results from an anomalous outpouching of the parietal pericardium. These are common in the right and left costophrenic angle, more often on the right. These do not communicate with the pericardial sac. So pericardial cyst can give you these round masses in contact with the pericardium, very commonly in the cardiophrenic angle, fluid attenuation, thin wall, no nodularity, no enhancement, So that is a pericardial cyst. The differential diagnosis for cardiophrenic angle mass, epicardial fat pad or lipoma. In this case, this is a fat pad, and you can suspect that because it is rather lucent. You can see through it. You can see the blood vessels there behind the lesion. We've discussed pericardial cyst. Of course, you can have a foramen Morgagni hernia. And we've also talked about recurrent lymphoma, especially recurrent Hodgkin's lymphoma, that can give you lymphadenopathy within the cardiophrenic angle. So here's a fat pad here. So again, lucent, you can see through it. You can see the blood vessels on the lateral view. That's triangular shape, very characteristic of a fat pad in the mediastinum adjacent to the pericardium. Nicely confirmed here on the CT scan. You can see this is mediastinal fat, very large fat pad causing that density on the chest radiograph. So what about this case? Well, here we have some kind of opacity here at the right lung base. Notice it contains air in it. So is this empyema with air? Is this a cavitary lung mass? Is this a necrotizing pneumonia? Well, whenever we see air like this at the lung base, you must also consider if this is bowel. So this turns out to be a large Morgagni hernia containing bowel. Okay, now let's discuss this case. Here we have an anterior mediastinal mass, so there are multiple findings. If we put them together, we can get to the right diagnosis. On the second image, notice in this expansile lesion here of the left humerus, pathologic fracture. This image, there's an expansile lesion of this rib, and on the last image, there is this large left renal stone. So can we put all these findings together? Anterior mediastinal mass, renal stone, expansile lesions there within the bones. So it turns out this is a patient with hyperparathyroidism. So this is an ectopic parathyroid adenoma, and these are brown tumors, and the hypercalcemia results, of course, in the renal stone. So an ectopic parathyroid adenoma. In patients with primary hyperparathyroidism, surgical neck exploration with resection of the parathyroid tissue is usually curative, but if the patient remains, if the hyperparathyroidism remains after surgery, that suggests that we have ectopic parathyroid tissue, and in 50% of cases, the ectopic parathyroid tissue will be in the mediastinum, and 2/3 in the superior mediastinum near the tracheoesophageal groove. In 1/3 of cases, though, it can be in the anterior mediastinum within the thymus. These tend to be small lesions, and these tend to be enhancing lesions. Usually you don't find these incidentally, you find these because you're looking for them given the clinical history. So these are vascular lesions, and they will enhance with contrast. Nowadays, of course, we look for these with sestamibi. So on the sestamibi scan, we can see uptake within salivary glands, uptake in the thyroid, but here is uptake within the ectopic parathyroid adenoma. These lesions are also very bright on T2-weighted imaging if you happen to do MR for ectopic parathyroid adenoma. All right, so here's our next case. We have this low attenuation, fluid attenuation mass here in the superior mediastinum extending down. Notice it is insinuating between the blood vessels here, kind of sneaking in between the blood vessels, fluid attenuation mass. And a clue on T2-weighted imaging, there are septations here within the lesion. So what does this turn out to be? Well, this is a lymphatic malformation. This is a lymphangioma. So this is unusual in the mediastinum. These tend to occur in the neck, but can extend down into the mediastinum, especially in children. You can have lymphangiomas, though, that are confined to the mediastinum in older children and adults. So these can be classified as capillary, cavernous, or cystic, with cystic hygroma being the most common. These can occur in all mediastinal compartments, but most commonly in the anterior mediastinum, especially in the anterior superior mediastinum here, extending downward. And the clue is that they are fluid attenuation, and you may have septations there within the lesion. They may be unilocular or multilocular, but the septations are a clue that you're dealing with a lymphangioma. So septated mass near the thoracic inlet with of fluid attenuation. Okay, now what about this case? Again, we have this large anterior mediastinal mass, And the reason I show this case, the diagnosis is obvious here on the CT. This is a large pseudoaneurysm. When we have these kind of pseudoaneurysms in unusual locations, we might think mycotic aneurysms. So the reason I show this is that don't forget about aneurysm for any of the mediastinal compartments. Any mass that you cannot separate from the great vessels, you do need to consider aneurysm in your differential diagnosis, especially if you're being asked questions about biopsying the lesion. So a very large pseudoaneurysm there arising from the ascending aorta. This case too, this seems to be a mediastinal mass here, but it turns out that in this particular case, the diagnosis was actually lung cancer. This was lung cancer invading the mediastinum rather than a primary mediastinal mass. So lung cancer is more common than any of these mediastinal masses that we are discussing. So it is very important to ask yourself the question when you come across a mediastinal mass, is it possible that this is lung cancer invading the mediastinum, or is this a primary mediastinal mass? Here the center of the lesion appears to be located outside of the mediastinum, so that might be a clue that we're dealing with a lung cancer here, a parenchymal lesion extending into the mediastinum rather than a primary mediastinal lesion. So in summary, in terms of making the diagnosis of these mediastinal masses, we could make diagnosis based on CT appearance, predominantly solid, fat, or predominantly cystic. If we're dealing with predominantly solid lesions, thyroid mass should connect to the thyroid. Lymphoma, look for lymphadenopathy elsewhere. Thymoma, associated with myasthenia gravis. Seminoma, this occurs in young males. Here's an example of a thymoma. Here's an example of a seminoma in this young male. Very aggressive mediastinal tumor. If there's fat on CT, if the lesion is predominantly fat, almost the entire lesion, then we think of thymolipoma. If there are fatty components within the lesion, but we have other components like fluid and calcification, then we think of teratoma. If it is cystic on CT, if it's a unilocular cyst, thin wall, no enhancement, no nodularity, then might be a benign thymic cyst. On the other hand, if there's thickening of the walls, if it's multiloculator, we need to think of cystic neoplasms. So we might have cystic change within a seminoma, or occasionally the cystic changes within a thymoma. Pericardial cyst contacts the pericardium. Lymphangioma or cystic hygroma, these are cystic masses that mold to adjacent structures. These may be septated, usually at the thoracic inlet. So that is our discussion of anterior mediastinal masses. So these are all the lesions that you should be familiar with at this point. And I thank you for your attention, and we will see you next time.